حضرتك ميوتد دكتور محمود؟
سامعني كده؟
صباح الخير يا بيه، اخبار حضرتك ايه؟ دكتور
صباح النور
محمود.
دكتور مجدي.
دكتور
صباح
محمود،
الخير.
صباح الخير، ازي حضرتك؟
الحمد لله والله بخير.
بنشكر سعادتك طبعا ان يعني يوم الجمعة بدري يعني حضرتك تشاركنا في الميتنج المهم ده ان شاء الله.
ان شاء الله خير باذن الله.
اتفضل يا دكتور هاني.
نبتدي ولا ايه؟
صباح الخير يا جماعة. طبعا يعني بنرحب بحضراتكم اليوم الثاني، عشان برضو أستاذ الدكتور هاني راجي طبعا اللي بنسعد بوجوده معانا النهاردة. طبعا أستاذ الدكتور هاني راجي غني عن التعريف، أستاذ القلب في معهد القلب والرئيس السابق لقسم القلب في معهد القلب، واحد طبعا من الناس يعني الاكسبرتس في الكارديولوجي والانترفنشن، ويعني وله باع في كل الحقيقه سب سبيشاليتيز في الكارديولوجي. استاذ الدكتور محمود حسنين طبعا يعني استاذ القلب بجامعه الاسكندريه، وطبعا الرئيس السابق لشعبه هبوط عضله القلب وواحد من المؤسسين لهذه الشعبه. والدكتور محمود طبعا يعني له باع كبير في تخصص الهارت فيلير، واحد مع يعني استاذي المرحوم استاذ الدكتور وجدي عياد هم اللي انشأوا تخصص الهارت فيلير في مصر. فطبعا برحب باستاذ الدكتور محمود حسنين النهارده. برضو للدكتور هاني والدكتور محمود، احنا ده كورس هارت فيلير للمستشفيات التأمين الصحي، وامبارح كان بيشرفنا الدكتورة فاتن مديرة الإدارة العامة للتدريب، وكان اول يوم امبارح يعني الحضور الحقيقه امبارح طبعا، وده اكسبكتد ان الحضور يوم الخميس يبقى اكتر من الجمعه. وكان الكورس امبارح عباره عن الدايجنوزس والمانجمنت اوف هارت فيلير with reduced ejection fraction. بشكر طبعا كل الاساتذه اللي امبارح شرفونا والقوا محاضرات رائعه الحقيقه. والكورس طبعا لسه فيه له تكمله الاسبوع الجاي خميس وجمعه برضو، عشان نبقى غطينا كل التوبكس بتاعه الهارت فيلير. النهارده الحقيقه فيري امبورتنت سيشن اللي احنا هنبتدي دلوقتي، اللي هو الهارت فيلير وذ بريزيرفد ايجكشن فراكشن، وده عليه بقى يعني ديبيت وفي a lot of يعني debatable issues regarding the diagnosis والمانجمنت. فعشان كده طبعا بيشرفنا الاستاذ الدكتور محمود حسنين والاستاذ الدكتور هاني راجي، وان شاء الله يعني يبقى سيشن متميز زي امبارح. فمن غير عشان ما نتاخرش، طبعا I have the pleasure to invite طبعا بروفيسور محمود حسنين. He is going to present diagnosis of heart failure with preserved ejection fraction.
بسم الله الرحمن الرحيم. بشكر اخي العزيز الاستاذ الدكتور مجدي عبد الحميد for his nice words. دكتور مجدي الحقيقه من الاعلام المصريه اللي بنفتخر بيها، وهو يمثلنا في اليوروبيان سوسايتي اوف كارديولوجي. فانا بشكره على his scientific activity. He is very active، واحنا الحقيقه يعني بنلهث وراه. بحيي وبشكر الاستاذ الدكتور خالد شكري رئيس الجمعيه المصريه لامراض القلب. اكيد انا بحيي الدكتور محمد السيد ضاحي رئيس مجلس اداره هيئه التامين الصحي، والدكتوره فاتن عماره مديره اداره التدريب على يعني مشاركتهم معنا واهتمامهم بالتعليم الطبي المستمر للاطباء التامين الصحي. ولازم اشكر شركه نوفارس لرعايه هذا الويبينار. عشان ما اطولش انا اخش في الموضوع على طول. diagnosis of HFpEF دي is always challenging، هي صعبه فعلا even for the sometimes even for the specialist in order to diagnose correctly الHFpEF. we'll go step by step. اولا الuniversal definition and classification of heart failure اللي ظهر في 2021 by Beacom Bosworth of the Heart Society of America، كان جوينت مع European Society of Cardiology Japanese Society of Cardiology. الديفينيشن of heart failure عامة هو symptoms and or signs of heart failure caused by structural or functional cardiac abnormality. مهم قوي كلمة symptoms and or signs. لازم نعرف ان diagnosis of heart failure is a clinical diagnosis. Always look for symptoms and signs. وده is corroborated يعني supported by at least one of the following اللي هو elevated natriuretic peptides or objective evidence of cardiogenic pulmonary or systemic pulmonary congestion. يبقى ده ال definition in general of heart failure. Heart failure with preserved ejection or any other method of ejection fraction is 50% or above that level. Why is Fpf important؟ احنا مهتمين قوي بالHfpef في الايام دي لان الحقيقه الHfpef is increasing by 1% per year relative to HFrEF. زي ما احنا شايفين on the left panel of the slide, rising prevalence incidence of HFpef. لو بصينا على الرايت بانل of the slide هنلاقي ال preserved ejection fraction بيزيد is on the rise, بينما ال HFrEF اللي هو heart failure with reduced ejection fraction يا اما is stable or even declining. ال HFpef robs the patients from their independence and the ability to live their lives. The quality of life بتقل قوي في العيانين دول. It's most of the time it's a female, it's a woman. فهيبقى في صعوبة في الجروسري shopping, climbing stairs, working in the garden, doing chores around the house, visiting family and friends, and maintaining intimate relationships. يعني quality of life is really is a mess, a big mess for those patients. Mortality is lower in HFpef than HFrEF. So whether heart failure with mildly reduced ejection fraction اللي كنا بنسميه mid range أو HFpef المورتاليتي is lower. كمان non-cardiovascular mortality is higher in HFpef. لو بصينا في الHFpef هتلاقي الكارديوفاسكولار mortality 60 ل 70% من الحالات، بينما النون كارديوفاسكولار mortality هي بتوصل ل 30 ل 40%، وممكن النون كارديوفاسكولار mortality تبقى renal أو infection, sepsis, malignancy, respiratory diseases. الHFrEF 80 ل 85% of causes of mortality are due to cardiovascular diseases. كمان ليه بنهتم بالHFpef؟ لأن في enormous health resource utilization، بالذات الhospitalization هو الcost of heart failure mainly due to hospitalization مش just medicines. يعني مثلا في United States mean cost of index hospitalization ranges from 8,340 US dollars لغاية 11,366 دولار for those without specific comorbidities. نيجي لموضوع comorbidities in heart failure with preserved ejection fraction. الحقيقة there are multiple comorbidities زي ما احنا شايفين في السلايد. ممكن يكون العيان عنده lung disease COPD, chronic obstructive pulmonary disease, iron deficiency and anemia, renal dysfunction, aging and deconditioning, obesity, psychiatric disorders like depression, hypertension, diabetes, valvular heart disease, elevated blood pressure, vascular dysfunction, autonomic dysfunction, atrial dysfunction, and ventricular dysfunction. So many multiple comorbidities, وده بيؤدي إلى increase in the heterogeneity of HFpef. يعني ما عندناش شكل واحد محدد للعيان الHFpef بعكس الHFrEF. We know العيان heart failure reduced ejection fraction جاي بشكل معين ما بيتغيرش من عيان للتاني إلا في حدود ضيقة جدا. لا، هنا في الHFpef there are so many different phenotypes of HFpef. كمان الهيتروجينيتي دي complicates management لأن العيان بياخد other medications زي بيتا agonist أو non steroidal anti-inflammatory drugs, and this complicates the management of those patients. كمان الcomorbidities are كمان زي ما اتفقنا non-cardiac outcomes constitute a significant proportion of mortality in HFpef patients. basket diagnosis في حاجات كتير قوي داخل الباسكت. It's not just heart failure. Obesity, برضو this is one major problem in patients with HFpEF وhas great implications. هنتكلم على الobesity بعد كده. This is a salient feature of heart failure with preserved ejection fraction. دايما الدايجنوزس is challenging زي ما قلت، وبنعزو السبب shortness of breath. العيان بيقول I am old already، انا عجزت وكبرت وطبيعي انا هنهج، او due to the medications I'm taking I'm hot and tempered or too anxious. Sometimes we are looking for other excuses other than diagnosis of heart failure. What are the risk factors and findings consistent with heart failure؟ امتى في زي كده red flags لما ابص او اعرفها اقول ده العيان ده غالبا عنده HFpEF. advanced age اللي هو 70 women. بس عايز اقول بقى هنا احط تحت الادفانسد ايج دي خطوط كتيره، لان في مصر في فرق كبير في الايج. احنا عندنا الميديان هارت فيلير الايج اوف بيشنتس هوسبيتالايزد هارت فيلير في مصر اقل ب 13 او 14 سنه من those patients in United States and in Europe. يعني عندنا الميديان ايج of our patients هو 60، ف 70 و75 دي ارقام بتتكلم على يوروب اند امريكا، لكن في مصر على الاقل هتشيل 10 years فهتقول ان هو غالبا في المان من 55 ل 60، وبرضه يمكن in women the same age. overweight obesity زي ما اتفقنا ده هي a major feature of HFpEF. metabolic syndrome, diabetes, physical inactivity, deconditioning, hypertension, atrial fibrillation, ECG abnormalities, and elevated natriuretic peptide levels. Legal scores, there are mainly two scores for diagnosis of heart failure with preserved ejection fraction. في American one اللي هو بتاع Mayo Clinic by Reddy et al. This is the simpler one. It's simple, more practical, it's sensitive but less specific. هي دي مفيدة قوي للجنرال practitioner لأن هي it will raise the likelihood of HFpEF، لكن السبيسيفيسيتي هتبقى قليلة. ايه السكور ده بيقول؟ هو اسمه H2FPEF. H2 for H for heavy and hypertensive. heavy يعني body mass index أكتر من 30 كيلوغرام per square meter، ودي بتاخد 2 points. إذا كان العيان hypertensive أو anti hypertensive medications بياخد 1 point. atrial fibrillation whether paroxysmal or persistent بياخد 3 points. دي نقطة مهمة قوي. atrial fibrillation 3 points. pulmonary hypertension إذا كان دوبلر ايكو estimated pulmonary artery pressure أكتر من 35 ملم mercury 1 point. elderly اللي هو more than 60 years 1 point. والفيلينج pressure اللي هو E over E prime by Doppler echo 1 point. فلو تصورت ان انا حسبت العيان السكور وطلع 6، هنبص تحت في البوتوم اوف ذا سلايد 6 معناه ان في البروبابيلتي اوف HFpEF is 0.9 يعني تقريبا 90% probably the patient is HFpEF. فthis is a simple score practical لكن السبيسيفيسيتي بتاعته يمكن قليله، فهو مفيد قوي for the general practitioner. نيجي لليوروبيان سكور بتاع اليوروبيان سوسايتي اوف كارديولوجي. هو بيكون من 4 phases اللي هو PEF، ال P for initial work up، E for diagnostic work up، F for advanced work up، و F for etiologic work up. نيجي ل step 1 اللي هو pre-test likelihood. البيشنتس with HFpEF are frequently seen by GPs. ده الحقيقة، ما بيروحش للكارديولوجيست على طول، لا بيروح للجي بي. وبالتالي the first step in diagnosis is to assess the likelihood of HFpEF in patients presenting with dyspnea on exertion or exercise intolerance. الاحتمالية الهارت فيلير. فالستيب 1 ده هي belongs mainly to the برضه the general and comorbidities. اذا كان ممكن تعمل البي ان بي يبقى كويس. ستاندرد ايكو اللي احنا كلنا بنطلبه. اي سي جي اذا كان ممكن 6 minute walk test ده هيكون مفيد. يبقى اذا ستيب 1 هي mainly for the GP، وهي ستيب 2 اذا كان البي ان بي ما اتعملش you have to do it. وبعدين we resort to comprehensive echocardiography. كلمة comprehensive يعني you resort to a professional echocardiographer. ودي نقطة مهمة قوي. الستاندرد echo may be done by any echocardiographer. لكن comprehensive echocardiography needs a professional diastolic dysfunction. Diastolic dysfunction is almost normal in the elderly. الكومبريهنسيف ايكوكارديوجرافي هنتكلم عليها ان ديتيل بعد كده. هي بتفيدني في السكورنج. لو السكور 5 بوينتس اور مور يبقى الهيف كان اقل من 1 بوينت او اقل يبقى الدايجنوزيس unlikely. لكن 40% of patients fall in a gray zone اللي هم بين 2 ل 5. Step 3 اللي هو diastolic stress test أو exercise stress echocardiography. We know that symptoms of HFpEF العين mainly on exertion. وبالتالي لو أنا بعمل echo during rest probably echo results will be negative for the diagnosis of HFpEF. You need to stress the patient with exercise عشان to elicit findings consistent with HFpEF. أحيانا you need invasive hemodynamic measurements with cardiac catheterization. Step 4 اللي هي final step اللي هو you are looking for etiology. لأن أحيانا في definite etiology للHFpEF زي ما هنتكلم بعد كده، زي مثلا cardiac amyloidosis أو restrictive cardiomyopathy. ففي الحالة دي بنلجأ ل cardiovascular magnetic resonance، ممكن cardiac or non-cardiac biopsies، scintigraphy، CT وPET genetic testing و maybe specific laboratory tests. ده الكومبريهنسيف ايكوكارديوجرافي مقسمينهم لميجر وماينور كرايتيريا. الميجر فانكشنال ومورفولوجيكال وبايوماركر. البايوماركر بالذات خلي بالك is an atrial fibrillation. فخلينا نركز على الاي اوفر اي برايم. اذا كانت اكتر من 15 او اكتر يبقى دي تساوي 2 بوينتس. اما اذا كانت من 9 ل 4 يبقى 1 بوينت. الترايكاسبيد regurgitation velocity by Doppler يعني البلمونري artery systolic pressure اكتر من 35 ملم مركي ده بياخد 2 بوينتس. اذا ما كانش موجود يبقى it's a negative sign. الجلوب هنا غالبا انه بيعتبروا minor criteria. اذا كان الجلوبال لونجيتيودنال سترين اقل من 16% it's 1 point. المورفولوجيكال اللي هو left atrial volume index لو اكتر من 34، اذا كان من 29 ل 34 يبقى it's 1 point. left ventricular mass index برضه اذا كانت اكتر من 149 يبقى 2 points، اقل من كده 1 point. البي ان بي الكات اوف اذا كان ساينس ريدم يبقى اكتر من 220 بايكوجرام بير ملي لتر. لو كان اتريال فيبريليشن بضرب في 3 على طول يبقى 660 كات اوف فاليو 660 بايكوجرام بير كيلوجرام. اذا كان اقل من كده من بي ان تي برو بي ان بي من 125 220 يبقى 1 بوينت. برضه اذا كان اتريال فيبريليشن بضرب في 3 يبقى الان تي برو بي ان بي من 365 660. زي ما اتفقنا لو السكور 5 points or more يبقى diagnosis of HFpEF is certain. اذا كان 1 point يبقى نيجاتيف. من 2 ل 4 دي الجراي زون. في الحاله دي بحتاج لدايستوليك ستريس تيست اور انفيزيف هيمودايناميك ميجرمنت. الستريس ايكو اللي هو غالبا بيبقى العيان نايم على السرير وبيعمل بايسكل سوباين بايسكل ارجومتري، او اذا كنت بجريه على تريدميل وفورا بنيمه على السرير واعمل الستريس ايكو. اذا كان الافريج اي اوفر اي برايم اكتر من 15 والترايكاسبيد ريجرجيتنج فيلوسيتي اكتر من 3.4 متر بير سكند يبقى دي ديفينيت دايجنوزس. اذا كان نو يبقى I may resort to invasive hemodynamic measurements اللي هو بالكاستر. الكاستر برضو بعمل ستريس تيست during the caster. اذا كان اندستوليك بريشر اكتر من 16 او pulmonary capillary wedge pressure اكتر من 15 يبقى diagnosis of HFpEF is definite. اذا ما كانش كده you stress the patient, exercise the patient برضه supine ergometry. المفروض الويدج بريشر يبقى فوق ال 25 عشان اشخص الهاف باف. الايتيولوجيكال ورك اب اللي هي في ستيب 4 هيبقى في ergometry عشان تشوف البلاد بريشر كنترول ومانجمنت اوف chronotropic incompetence and ischemia work up. لازم you should look for underlying coronary artery disease in HFpEF patients. كمان السي ام ار اللي هو cardiac magnetic resonance for ischemia work up and for cardiomyopathy work up. يمكن ده سلايد بتلخص الالجوريزم. لما بيجي لك عيان breathless patient، عيان بينهج، زي ما اتفقنا ستيب 1 clinical assessment compatible with HFpEF اللي هو standard echo including nitrotic peptides, ECG, X-ray وايكوكارديوجرافي. ده زي ما قلنا ستيب 1 for the likelihood of HFpEF. ستيب 2 اللي هو comprehensive echo، بنشوف باي ايكو الباف سكور. اذا كان لو يبقى نيجاتيف دايجنوزز، اذا كان هاي يعني 5 فيما فوق يبقى ديفرنت دايجنوزز. انترميديت الجا للدايستوليك ستريس تيست، موستلي بيتعمل نون انفيزيف باي ايكو كارديوجرافي، لكن ممكن احيانا in few cases احتاج لانفيزيف دايستوليك ستريس تيست. اذا كان abnormal يبقى الهاف باف دايجنوزز كونفيرمد. وستيب 4 اللي هي الفاينل ستيب you investigate for specific etiology. ده يمكن فكره سريعه عن الدايناميك دايستولوجي اللي هو الفيلينج بريشر اي اوفر اي برايم، اي باي دوبلر ايكو والاي برايم باي تيشو دوبلر. المفروض مع الاكسرسايز الاي فيلوسيتي بتزيد، والابنورمال ان الاي will rise بينما الاي برايم هتفضل زي ما هي، وبالتالي الريشيو هتزيد. يبقى اذا الاي اوفر اي برايم اللي هي left ventricular pressure does not increase much with exercise in normal heart but increases in symptomatic. بيورينا هنا العيان الاي اوفر اي برايم at rest 13 with exercise الاي اوفر اي برايم بقت 24، من 13 زي ال 24. وبرضه باي كاستر البلمونري ارتري ويدج بريشر كان 8 and this confirms the diagnosis of HFpEF. اخر حاجه، اخر جزء في my talk is HFpEF in Egypt. شويه يعني حقائق الوضع في مصر مختلف شويه عن بره. ده كان part of the of hospitalized patients in Egypt. كان العدد مش بطال 1608 patients. هنلاحظ حاجه مهمه قوي، الايدج Egyptian patient اللي فوق ال 70 كان في مصر حوالي 23% of the patients enrolled in the registry، بينما اليوروبيان كان 60%. فرق كبير قوي. فرق في الميديان ايج حوالي 13 او 14 patient. والفرق في الايج ده هو makes great difference في الديموغرافيكس والبريفالنس of HFpEF in Egypt عن اليوروب. الاوبيزيتي كمان it's a major health problem in Egyptian patients. زي ما احنا شايفين البريفالنس of obesity في الومن كان على اليمين 61.3%، بينما في المان او في الميلز كان almost 40%. فرق كبير. الاوبيزيتي in females is a big problem. كمان الاوبيز they have more prevalence of diabetes, hypertension and myocardial infarction. نيجي نبص بقى على الهاف باف obese versus non-obese patients hospitalized heart failure. هتلاقي ان الهاف باف versus 12.4 بالنون اوبيز. هنا ماجنيفايد ادي الهاف باف الاوبيز. وده على فكره ده برضه the same figure تقريبا in the same registry of hospitalized heart failure patients in Egypt. HFpEF only 22.3% versus 12.4% in the non-obese. نيجي بقى sex، هل بيفرق؟ Yes, it makes a great difference. هنلاقي ال prevalence of HFpEF in obese women بيوصل almost 32% versus 15.1% in obese men. واضح قوي الفرق ما بين الاوبيز وومن والاوبيز مان. الاوبيز وومن كمان had more prevalence of diabetes, hypertension. كمان حاجه مهمه قوي incidence او prevalence of atrial fibrillation 34.4% in women versus 22.5% in men. وبالتالي لما نيجي نقول why HFpEF is more common among women hospitalized with heart failure in Egypt لاسباب زي الاوبيزيتي, more comorbidities in females, diabetes, hypertension, anemia, and more prevalence of HFpEF is mainly a disease of women. The conclusions, this is my last slide, it becomes clear that HFpEF can be diagnosed now. Its diagnosis is difficult and challenging, like exercise testing may be part of the diagnostic approach, and the exclusion of coronary artery disease may be key. Again, HFpEF is primarily a disease of women who comprise 60 to 70% of the HFpEF population. Increased awareness regarding HFpEF is important if we are successful in finding a therapy for HFpEF. واعتقد ان في اخبار ساره جدا في اليومين اللي فاتوا عن successful treatment of HFpEF with the sodium glucose transport 2 inhibitors. Then we will need to know how to find the eligible patients. Thank you for your attention. دكتور مجدي اتفضل.
Professor Mahmoud Hassanin, thank you, and Hani Ragi, thank you. This was an absolutely wonderful and illustrative presentation. It was very clear. Professor Magdi suggests that we keep the discussion to the end because the whole session is very related. Are you going to be with us to the end for any questions, or لو في أي حاجة ملحة جدا الآن؟ Otherwise we'll move to the next presentation. يشرفني إن أنا أقدم البروفيسور مجدي عبد الحميد, Professor of Cardiology, Cairo University. هو غني عن التعريف, بس الحقيقة يهمني أقول إنه في الفترة الأخيرة في مجال الهارت فيلير البروفيسور مجدي عبد الحميد خدنا كمصريين وكجمعية القلب وكالمهتمين بالهارت فيلير لمجال الدولية, وهو من الأوثرز بتوع الجايد لاينز وبتوع البيبرز الحديثة في الماسيف امباكت جورنالز, ودي حاجة بتخلي طبعا درجة الفخر الشخصي بتاعنا وهو ما نتوقعه يعني كبيرة جدا. بلس برضو دي حاجة اوف ريكورد ان هو زي من مشجعي الزمالك المصري, فدي حاجة مقربانا قوي لبعض. Professor Magdi Abdel Hamid, our Egyptian expert, like Professor Mahmoud Hassanin, who's also our Egyptian expert, and today I'm humbled, يعني أنا ما استاهلش أكون هنا جنبهم بصراحة. Will talk to us about heart failure with preserved ejection fraction, ما يسمى ال HFpEF, which we just heard how to diagnose it. Now we're going to hear about the treatment updates. Professor Magdi.
Thank you very much, my dear friend, Professor Hani Ragi, على الكلام الكبير اللي أنا ما استحقوش يعني. فالحقيقة دكتور هاني يعني دكتور هاني له يعني أقول إيه في كل تخصصات القلب, intervention, heart failure, amyloidosis, smoking cessation programs, يعني دايما الحقيقة في كل المجالات القلب تلاقي الدكتور هاني له بصمات وله يعني leadership في كل الأمراض اللي تخص أمراض القلب, ودايما بيفوكس على الأويرنس على حاجات يمكن الناس كتيرة في تخصص القلب ما تاخدش بالها منه. فدكتور هاني الحقيقة يعني وجوده معانا النهارده طبعا يعني ده شرف كبير للكورس اللي احنا بنعمله. شكرا دكتور هاني. طبعا thank you very much Professor Mahmoud Hassanin because it is a very difficult and very challenging topic. We know in details heart failure with reduced ejection fraction, and we know that we have guidelines which is updated 1 week ago. But what about heart failure with preserved ejection fraction? The heterogeneous disease, as mentioned by Professor Mahmoud, do we have new drugs which can improve survival for this disease? and what is the current recommendations regarding treatment. In short, heart failure with preserved ejection fraction, the prevalence is increasing. It represents 50% of cases of heart failure is heart failure with preserved ejection fraction. High morbidity, mortality, multiple pathophysiologic contributors. Unfortunately, until recently, few therapies are available. So we need new solutions regarding how to diagnose it properly and how to treat it accurately. So who are these patients? As mentioned by Professor Mahmoud, the typical demographics and comorbidities with this disease, a lot: advanced age, hypertension, atrial fibrillation, common in females, kidney dysfunction is common, metabolic abnormalities, metabolic syndrome, obesity, deconditioning, COPD, pulmonary hypertension, sleep apnea. And the pathophysiology is a complex with a lot of pathophysiological abnormalities such as impaired feeling, increased stiffness, impaired relaxation, chronotropic incompetence, autonomic dysfunction, vascular stiffness, increased vascular dysfunction, and dynamic mitral regurgitation. So all these comorbidities and all this cascade of pathophysiological abnormalities are responsible for the syndrome of heart failure with preserved ejection fraction. So this may explain why the treatment fails over many years to drugs which improve survival for this challenging disease. And we know the guidelines 2016 regarding the criteria for diagnosis. It is symptoms and signs of heart failure, ejection fraction 50% or more, high level of natriuretic peptides, at least one additional criteria, which is relevant structural heart disease like LVH and the left atrial enlargement, diastolic dysfunction. Until recently, and now also, we have the treatment options to give diuretics to relieve symptoms and signs of congestion, of course, and it can reduce hospitalization. Lifestyle intervention, exercise training can improve functional capacity and quality of life. Mineralocorticoid receptor antagonists, management of comorbidities, treatment of hypertension, treatment of myocardial ischemia, and rate control for atrial fibrillation. These are the main steps for treatment of heart failure with preserved ejection fraction. And this slide summarizes the different trials for the different drugs. Charm preserved, the use of candesartan program for Charm trial, and unfortunately, the drug failed to show primary endpoint reduction, cardiovascular death and heart failure hospitalization. However, it was associated with reduction of hospitalization. The same for perindoprel in PIP heart failure trial, the same for irbesartan in I-preserved trial. These drugs did not improve the outcome. And regarding spironolactone in TOPCAT trial, no statistically significant difference. However, the outcome was different geographically. The outcome was better in American versus Russia and other countries. So the guidelines, American College, American Heart Association, is to give diuretics, should be used to improve symptoms due to overload, volume overload, class 1 recommendation. Beta blockers, ACE inhibitor, ARPs if hypertension, class 2A recommendation. Angiotensin receptor blockers might be considered to decrease hospitalization, class 2B recommendation. What about the European guidelines? European recommended diuretics to relieve congestion in order to relieve symptoms and signs of congestion. And also the American recommended spironolactone, aldosterone antagonist, class 2B recommendation in patients with heart failure with preserved ejection fraction 45% or more, with elevated natriuretic peptides. GFR should be more than 30 milli per minute, creatinine less than 2.5, potassium less than 5. And this is class 2B recommendation. So in the last 3 years, we have sacubitril valsartan which was proved to be effective in treatment of heart failure with reduced ejection fraction in paradigm heart failure trial. So what about the use of Entresto, sacubitril valsartan, in heart failure with preserved ejection fraction? This was an initial small study, which is a Paramount study, and it demonstrated the significant reduction in natriuretic peptides and reduction in left atrial size. However, there was no statistically significant difference in the NIHA function class. And then the big study for sacubitril valsartan, which is Paragon heart failure trial. And in Paragon heart failure trial, was randomized, double-blind, active comparator test trial to test the hypothesis that sacubitril valsartan compared with valsartan would reduce the composite outcome of total heart failure hospitalization and cardiovascular death or not. So randomization to sacubitril valsartan 200 milligram twice per day versus 160 milligram twice per day valsartan, looking for the primary endpoint, which was composite of total heart failure hospitalization and the cardiovascular death. And secondary endpoints, improvement in NIHA function class, Kansas City cardiomyopathy questionnaire to evaluate and assess the function capacity, time to first occurrence of worsening renal failure, and time to all-cause mortality. And these are the key inclusion criteria: above the age of 50, ejection fraction more than 45, heart failure function class 2 to 4, structural heart disease, high levels of natriuretic peptides. They excluded patients with ejection fraction less than 40%, current acute decompensated heart failure, hypotension, or very high blood pressure. What about the results? If this drug is effective, like heart failure with reduced ejection fraction, which is class 1B recommendation in the guidelines, the primary endpoint, unfortunately, did not reach to statistically significant p-value, a borderline p-value 0.05, with a non-significant 13% reduction in the primary outcome, which was total heart failure hospitalization and the cardiovascular death. And the same for the components of the primary endpoint, cardiovascular death and the heart failure hospitalization. The risk reduction mainly due to reduction in heart failure hospitalization, no effect on mortality. It did not decrease cardiovascular death. And if we look for the secondary endpoints, improvement in symptoms, quality of life, and preservation of renal function. So it has a favorable effect on secondary endpoints. But interestingly, they did sub-analysis of the study. And the sub-analysis proved that the drug was statistically significant in female gender, females, and ejection fraction from 45 to 57%. So this is an interesting findings which indicate that the drug could be effective to treat HFpEF in those populations, females and ejection fraction 45 to 57%. So this slide summarizes nebivolol, beta blocker, which significantly reduced all-cause mortality or hospitalization in senior trial. Candesartan, again, non-significant in charm preserved, and the sacubitril valsartan, the sub-analysis in women, and ejection fraction 45 to 57%. So this slide summarizes the different major randomized clinical trials, which I mentioned: PEP, heart failure, perindoprel, charm, preserved, candesartan, iPreserve, Paramount, Paragon, TopCat, all major trials. And is there a role for intervention? This study evaluated the effect of interatrial septal device as creating like atrial shunt at the level of the atrium to decrease the left atrial pressure and decrease congestion. And in this short, small trial, it was associated with significant reduction in the wedge pressure compared with the baseline wedge pressure in patients who were not subjected to this procedure, a study which was known as Reduced Lab Heart Failure 1. Recently, we are in the revolution for heart failure therapy, sodium glucose cotransporter inhibitor. The winner of the last 2 years for treating cardiovascular disease, heart failure with reduced ejection fraction. As we mentioned yesterday, it is class 1A recommendation in the new guidelines, dapagliflozin and empagliflozin. So is there any role for SGLT2 inhibitor in treating heart failure with preserved ejection fraction? Yesterday, we mentioned the suggested mechanisms for the use of SGLT2 inhibitor in heart failure with reduced ejection fraction, as it inhibits the reabsorption of glucose in the proximal convoluted tubules at SGLT2 protein, so it induces glycosuria, natriuresis, osmotic diuresis, decreased preload, decreased afterload. It improves cardiac function, decreased arrhythmias, it improves the arterial wall vascular function. It has a renoprotective effect. It improves renal function. Although we might see an initial decline in the GFR in the first 2 weeks after initiation of SGLT2 inhibitor, but after 2 weeks, there is a preservation of the renal function over the long term. So this is considered as the first heart failure treatment drug which improves kidney function. So at the end, these drugs decrease cardiovascular death, hospitalization for heart failure, and decreased renal events. So this explains why this group of drugs are now class 1A recommendation for heart failure and should be given for all heart failure with reduced ejection fraction from day one, single dose, no titration, and can be given for diabetics as well as non-diabetics. No risk for hypoglycemia in non-diabetic patients. So this is ongoing study for heart failure with preserved ejection fraction, which is delivery study, to receive dapagliflozin 10 mg or placebo up to 39 months, looking for the primary endpoint, which is the first occurrence of any components of cardiovascular death, hospitalization for heart failure, urgent heart failure visits. It's ongoing. We did not have any results for 6,000 patients included in the study. The other study, which is Emperor preserved for empagliflozin, 10 mg compared with placebo for 38 months, primary endpoint, cardiovascular death, heart failure hospitalization, for ejection fraction more than 40%. And we are lucky. Now we are lucky that this is the first drug. 2 days ago, the results have been released for the efficacy of empagliflozin in decreasing the primary endpoint, cardiovascular death and heart failure hospitalization. So this is the first winner for patients with HFpEF, a disease which we did not achieve any success over many years. This is the first drug, empagliflozin, in heart failure with preserved ejection fraction. 2 days ago, they announced the results, but the complete study will be presented in the ESC at the end of August. So we are waiting a complete analysis, complete results of this study, but the conclusion that this drug is effective in heart failure with preserved ejection fraction. Again, this is a breakthrough in medicine in the last years, that now we have drug which decrease mortality in heart failure with preserved ejection fraction. So in conclusion, diagnosis and treatment of HFpEF are challenging for the clinicians many clinical trials have neutral results for many years. Paragon was effective regarding sub-analysis in women and ejection fraction 45 to 57%. And now effective therapy for HFpEF exists. Now we have empagliflozin according to the initial results of Emperor Preserved. Thank you for your attention.
Thank you very much, Professor. احنا ماشيين بالنسبة للوقت كويس وهنخلص ميعادنا قبل الصلاة طبعا. I would like to open the floor إذا كان في أي أسئلة ملحة ولا أوكي. شكرا.
Now I have the pleasure to introduce Professor Hani Ragi. Professor Hani Ragi is going to talk about a very important and very difficult to diagnose because it is underdiagnosed in the daily clinical practice and it's also correlated and involved in heart failure with preserved ejection fraction. This is one of the phases of HFpEF, which is cardiac amyloidosis. دكتور هاني has a special interest in amyloidosis ويعني من اوائل الدكاتره اللي اتكلموا الحقيقه على الكاردياك amyloidosis وان هو يعني how to diagnose it وهو why it is commonly missed in the daily clinical practice and how to screen for this undiagnosed and this challenging disease. Professor Hani Ragi.
Thank you very much, Professor Magdi. Sabah al-khair. Good morning, everybody. I'm honored to be here today in the meeting of the Egyptian National Insurance Department, and I would like to talk about cardiac amyloidosis. What is amyloidosis? أولاً, let me explain why I'm interested in amyloidosis, because I had one patient, I missed him, and when I diagnosed him, it was too late, but he remained diagnosed for 2 to 3 months. And during this period, I went and I learned everything about amyloidosis, and I realized that if I had diagnosed my patient earlier, he would have survived. He died. And I was extremely upset, so I decided to dedicate more time to this condition. When I discovered that it was not just not rare, but it was actually common. So what is amyloidosis? What is it? It's a systemic condition where there is a protein that deposits extracellularly, known as the amyloid protein, in multiple organs, okay? There are many types. There are 23 types of amyloidosis, but we're gonna talk about what interests us and what's common and what's treatable. The amyloid, when it deposits around the cells, it obviously does a lot of things to the cells. It stops them functioning, it also kills them, and it leads to obstructions. So, sorry, let me go back. He changed this. How many of you have diagnosed the patient with cardiac amyloidosis in the last year, not in the last month? Please raise your hand. Okay. Let me tell you that there is no month in which I don't diagnose at least one case of cardiac amyloidosis. And in some months, it's more than one case a week. It's actually common, and I'll show you now. So, and 2 years ago, I was exactly in your position. So I'm not showing off, because it's just there, but we're not looking at it, okay? So today, we're running very quickly together. We're gonna learn how to look at it, and I'm even gonna give you a phone number so that if you suspect amyloidosis, you can call it. So this is the literature about cardiac amyloidosis. You know, when I was in medical school, it was barely mentioned, but there is a more than 1,000% increase in the word cardiac amyloidosis in medical journals. So what are the types that concern us? This one in the middle is actually not uncommon in Egypt, and you will see it in untreated familial Mediterranean fever. That is why we give patients colchicine. Everyone in this room knows somebody who's on colchicine in Egypt. Familial Mediterranean fever is common. You'll also see it secondary to rheumatoid arthritis. So chronic inflammation of familial Mediterranean fever, rheumatoid arthritis, will lead to AA amyloidosis, which is secondary amyloidosis, and that will lead to kidney failure. You diagnose it by proteinuria. You can take biopsies, and the treatment for the underlying inflammatory condition usually stops it, like giving colchicine for familial Mediterranean fever. Once patients with familial Mediterranean fever start developing kidney dysfunction, needle biopsy is very commonly done from the kidney in Egypt, and amyloidosis staining with Congo red. Any Egyptian high-quality nephrologist would have diagnosed many of those. And you go ahead and you treat the original condition. The two types of amyloidosis which are concern us, this one is very closely related to the myeloma. It's nearly a malignant condition, and it's called primary AL amyloidosis. The protein here is an immunoglobulin light chain, and it's very important if you think of amyloidosis, you have to rule this out in less than 1 week, because this is a very fastly fatal condition, and just refer it to an oncologist, okay? And how you rule it out is by 3 tests: urine and plasma, immune fixation, protein electrophoresis, and light chain analysis, plasma light chains, okay? Any lab, you just say, it's like the test for the myeloma. The second type of amyloidosis that we care about is called the TTR. TTR, and I'll show you in a minute, is transerythrin, which is a protein. The hereditary type does exist in Egypt in a couple of families, but what we really care about is the wild type. It used to be called senile, but it's not senile anymore. It's called the wild type. And the extent it affects the heart is 100%. So the wild type amyloidosis is a cardiac condition. It used to have no treatment when the slide was written, but now it actually has a specific treatment. This is the AL amyloidosis. If the plasma cells go wrong, they can deposit in the bone marrow, causing myeloma, or they can deposit around tissues, causing AL amyloidosis. And they can coexist, but they don't have to. If you think of cardiac amyloidosis, consider it AL till proven otherwise, and give yourself not more than 1 week to rule it out, as I just said. This is a time bomb which is going to kill the person in front of you, just like a myeloma would. They're easy to diagnose, and they are treated by chemotherapy with hematologists and oncologists. So what is TTR? TTR is transthyretin. That is the normal protein that we all have, which is made in the liver, which is a transporter protein that carries thyroxine and retinol, the vitamin. And if this protein misfolds, it causes amyloid. The non-hereditary type is just spontaneous fibril formation. It's called the wild type. It's in the heart, and predominantly in the elderly. You can see it now in younger people in their 50s, but the majority are in the elderly. More men than women. In old men, like, you know that if you do a prostate biopsy on men above the age of 80, do you know how many of them were going to have cancer prostate? More than 90%, okay? So more than 90% of old men will have cancer prostate, which doesn't need anything. You don't need to diagnose it, you don't need to treat it, you don't need to do anything about it. It's a very common condition as we grow old, because people did not used to live that long. But now, thanks to you, to modern medicine, people live. So wild-type amyloidosis is actually quite common, and in biopsies in older people, it's present in 25% with 100% cardiac involvement. I just want you to think of the extracardiac manifestations, because the same stuff deposits in your carpal tunnels. So if you want to diagnose amyloidosis, go to the bone surgeons in your hospital who operate on carpal tunnel patients and tell them, please, if you get a carpal tunnel patient who's an older patient, ask them if they have shortness of breath, or send them to me for an echo, and especially if it's bilateral carpal tunnel. The same for lumbar spinal stenosis And for ruptured biceps tendon, which I'm going to show you pictures of, you find an old man with a muscle شكلها زي محمد علي كلاي، يعني دراعه عامل كده لأن ruptured. It's painless, but his muscle looks strange. And these are red flags. Diagnosis of cardiac amyloidosis is delayed by at least 4 years due to lack of awareness and lack of recognition. And the time from, no, forget about this. The number of physicians which are visited for amyloidosis is huge because patients go to everybody. They go to a bone doctor, they go to an eye doctor. They miss, till they get referred to a specialist. So why is this happening? Because we don't have knowledge about the disease. It's not in our mind. The patient is sitting in front of us, giving us all the red flags, and we're telling them, أعصابك تعبانة or something like that. And also has unspecific clinical presentation, and it's perceived to be rare. يعني اسمه بالعربي الداء النشواني. انزل يركب المترو وقول للناس ايه هو الداء النشواني ولا حد هيعرف. Okay? So, and the same in physicians, by the way. So the patients can present with HFpEF, so they present with shortness of breath. They present with conduction abnormalities. So if you want to fish for amyloid patients, look at everybody who's coming for a pacemaker in your hospital. Look at everybody who has atrial fibrillation. Because if you think about amyloidosis, you're going to diagnose it. They can come with all sorts of arrhythmias. They can come with edema due to HFpEF, dizziness, chest pain, or fatigue. Non-specific. Think about amyloidosis. It's frequently misdiagnosed. It's diagnosed as hypertensive left ventricular hypertrophy, as HFpEF, hypertrophic cardiomyopathy, restrictive ischemic heart disease, aortic stenosis, and they do coexist. It's a disease that wears many hats. And by the way, it's very, very satisfying for the cardiologist to diagnose, and it's very easy, and I'll show you how. It really is easy. Once you think of it, it's easy. Next year, inshallah, ربنا يدينا العمر, if we meet here and we say how many diagnosed cardiac amyloidosis, I know that everybody who's in this room now will raise their hands. The classical picture هو left ventricular hypertrophy possibly small effusions. Usually the septum usually it's not asymmetric, and it's mild. It's usually like 12 millimeters or something, so it needs good echocardiography. The ECG بيعمل لك two patterns. أول حاجة, you see a lot of left ventricular hypertrophy on the echo. You expect to see big left ventricular hypertrophy here, right? There's none. It's small voltage. So there's a mismatch between the ECG and the echo. And you say, why am I not seeing the LVH on the ECG? And you also see the pseudo-infarct pattern, okay? And in this ECG, I think the patient is in atrial fibrillation as well, which is also, this is a very classical ECG of cardiac amyloidosis, okay, of the wild type amyloidosis. But the classical picture is the tip of the iceberg. HFpEF patients. HFpEF elderly patients, you should recognize them because they are not going to benefit from all the nice treatments we heard about. They need specific treatment. They might actually get much worse on ACE inhibitors and beta blockers, okay? So you might increase their symptoms and their mortality. In patients with HFpEF and left ventricular hypertrophy, in this study, there were 13% of patients, of the elderly patients with amyloidosis. This shows you how many we are missing. Everybody in this room has 0%. Okay, we're missing those. So when we talk about HFpEF, cardiac amyloidosis has to be ruled out. It'll take you 1 minute of thinking, but might save the patient's life. A lot of them will have preserved ejection fraction, and some will have reduced ejection fraction. What about if you actually get a patient with aortic stenosis and left ventricular hypertrophy? Guess what? If this patient, especially if they have what's called low flow, low gradient aortic stenosis, like Professor Ahmed al-Kardani here, he's sitting here, he treats them surgically. He does aortic valve replacement. So when we looked at a whole series of patients undergoing aortic valve replacement, guess what? 5.3% had ATTR cardiomyopathy. They had the highest mortality of the group and the least benefit after, no symptomatic benefit after aortic replacement. So they need specific treatment in addition to the aortic replacement. So if you want to find amyloidosis patients, go to the cardiac surgeons, check their aortic stenosis patients. And the same if you look at TAVI. In TAVI, it's even higher incidence. In this study, this is a separate study, looking at TTR amyloidosis when people just went to a group of patients, consecutive patients undergoing TAVI, and they found 16% had wild-type amyloidosis. Again, low gradient, low pressure, no benefit from TAVI, which is an expensive procedure. One of the causes of left ventricular hypertrophy, you should always think of amyloid. Patients who go to the EPS department, go and look for amyloidosis in those elderly patients with LVH who develop a heart block which is not obvious, not ischemic. If you start looking for all those patients, you're going to diagnose them early, and guess what? That will have a major impact on their survival, because now there is a specific treatment. There is a medication for amyloidosis, but it works much better if you diagnose them early. What about incidental diagnosis of amyloidosis? Amyloidosis now is diagnosed, cardiac amyloidosis, without a biopsy. Do you know the bone scan that we use for prostate cancer? It's called technetium-99 PYP or technetium-99 DPD. It's widely available in Egypt, in all the centers, and it's very, very cheap, okay? It's less than 500 pounds in the most expensive center. This diagnoses cardiac amyloidosis with 100% accuracy, almost 100% accuracy, without a biopsy, okay? So a lot of old men who are going to do a bone scan to rule out metastatic cancer were found by chance to have amyloidosis. Again, out of you know, I mean, this is like free. It's a free diagnosis. The person who's doing the scan just has to be aware when they look at the scan and it's the heart which is black, not the bones, that this might be amyloidosis. So this incidental amyloidosis was detected in a large study in 3.9% of males and less than 1% in females. So this is just a reminder: LVH, heart failure, conduction abnormalities, aortic stenosis. That's where you look. Where are these patients? These patients are everywhere. You know, you can find, there are females, they're not all males. Low voltage ECGs, echoes. The apical strain in the echo is very important. You should ask for strain, because the strain is dramatically reduced in amyloidosis, but the apical strain is preserved. You should always think about amyloidosis. These are the red flags which we spoke about. This is the ruptured biceps tendon. 32% of old men with ruptured biceps tendon will have wild-type amyloidosis. Speak to your orthopedist and your structural. The cardiac red flags, we spoke about them. This is the echo. The increased speckling, the LVH, you know, atrial septal hypertrophy. Sometimes the atrial septum is more than 1 centimeter thick, the granular speckling, the mild pericardial effusion, and the preserved ejection fraction. The late gadolinium enhancement on the MRI, but it's not terribly important. That is a very, very important, which is called the cherry on top. Preserved apical strain and severely reduced rest of segment strain. Let me just take you, this is a biopsy. This is the ECG which you spoke about. Just a moment, yeah. So when should you suspect ATR cardiac amyloidosis? Suspect it all the time, because it's going to take you a few minutes, just a few minutes, to rule it out or to do some investigation. If you don't think about it, you're not going to diagnose it. And there's nothing more insulting to a physician than missing a diagnosis which leads to the death of their patients. And of course, it's more than insulting for the patient, it's fatal. So it shouldn't happen. You should think about amyloidosis if you have left ventricular thickness and any one of those. Low voltage on the ECG, hypotension in a previously hypertensive patient, subendocardial late gadolinium enhancement, heart failure, Fpf, sensory involvement, carpal tunnel, pseudo-Q waves, AV conduction delays. The family history is quite important in the hereditary types. You should screen in everyday practice in any patient with symptoms of heart failure or any of the red flags that we just spoke about, who also has increased wall thickness. If there's no increased wall thickness at all, if your wall thickness is 0.8, you don't need to screen for amyloidosis. You should screen males above the age of 65 or females above the age of 70. If you look at this in your everyday practice, you're going to catch a lot of patients. This is my last slide. This is, please, من فضلكم, if you had gone to sleep or gone bored now, wake up. Because if you see the slide now, please take a picture of it. This is everything you need to know about amyloidosis. Okay? So this is the algorithm of diagnosing wild-type amyloidosis. You get signs and symptoms, Banaham, ECG, echo, cardiac MRI, suggestive cardiac amyloidosis, and then you do two things. You will have to do those two things. You will do tahleel dam and tahleel bol, okay? Hematologic study to discard AL amyloidosis within the first week of thinking. And you'll also send them for a technetium-99 PYP scan, which you have in your hospitals and it's present in all. This is a typical cardiac uptake in the scan. This is the one which has no cardiac uptake. So if you get this, okay, strongly positive, you don't need a biopsy. So let's work this. So this is A and this is B. If A is negative, so there's no AL amyloidosis, and B is negative, so there's no wild-type amyloidosis, then amyloidosis is unlikely, okay? Now, if A, tahleel al-dam, is negative, but B is positive, it depends how positive B is. If B is very strongly positive, class 2, 3, or 4, that is the very heavy uptake, then cardiac TTR amyloidosis is diagnosed and you don't need a biopsy. If B is weakly positive, you need histological confirmation. Cardiac biopsy is not done in Egypt, but we have other ways of doing biopsies in other tissues. Now, if A is positive and B is negative, this is AL amyloidosis. You're going to send them for non-cardiac biopsies, including abdominal fat or kidney, and going to send them to a hematologist or an oncologist. Now you have, if A is positive and B is positive, which is quite unusual, you need to send them to a big specialist for histological confirmation to see the subtype. You're very unlikely to see this combination, but not impossible. Last word, which is off-label. So what is the treatment? Okay, حضراتكم, you're aware in the last few days about the story of the young boy اللي كان عنده ضمور العضلات, and the Egyptian government has decided to make a deal with Novartis and get him a $4 million treatment every year. Okay. The treatment for cardiac amyloidosis is an expensive treatment, which is approved in Egypt. It costs about $250,000 a year per patient. It reduces mortality, reduces symptoms, and stops the condition. There will be more treatments coming soon with gene editing, but at this point in time, that's what we have. And the good news, again, is the Egyptian government and the manufacturer have their own pathways to get this treatment to our patients. So our patients, if we diagnose them, are going to get treated, okay? And they are not going to get treated paying $250,000 a year a patient. It's not going to happen. There are pathways, like we have seen before, which the government here knows how to do very well, and the international pharma is very interested. And I have put patients in those pathways. Some of them did not even make it to get the drug, but the pathway and the algorithm is very clear. I hope you enjoyed the presentation. I'm so grateful for your presence, and thank you very much.
Thank you very much, Professor Hani, for this elegant presentation. I think cardiac amyloidosis should be suspected in patients who have criteria of red flags as mentioned by Professor Hani. اتفضل دكتور هاني عشان نبتدي discussion. دكتور محمود حضرتك معانا؟
ايوه انا معاك
اتفضل. Questions. اتفضل يا دكتور.
شكرا. صباح الخير جميعا. Thank you very much for these wonderful presentations. I have two questions actually. The first question is with regards to the HFpEF and the transition from asymptomatic, like at a family medicine level or an internal medicine level, the transition from asymptomatic left ventricular systolic dysfunction to HFpEF, or asymptomatic low ejection fraction to HFpEF, or heart failure with mid-range ejection fraction. What are the criteria that facilitate this transition? What are the variables that will make the patient go, that I should look for, and will make the patient go from being asymptomatic to HFpEF or to heart failure with mid-range ejection fraction? So, thank you.
Professor Mahmoud, we have a question regarding the transition from asymptomatic HFrEF or heart failure with mid-range ejection fraction to HFpEF. This is the question?
Yeah, the criteria or the variables that I should look for as a family doctor or as an internal medicine. If a patient comes to me and I do echo and I find incidentally that his ejection fraction is 52% or 51% or 49%, and he's asymptomatic, so he doesn't have heart failure. So I want to look for him in the future to catch when he changes to HFpEF or heart failure with mid-range ejection fraction. So what are the points that I should focus on?
هو الرد على سؤال حضرتك، هو diagnosis of heart failure in general is clinical. يعني without symptoms and signs of heart failure you cannot diagnose. قلت العيان echo لقيت ejection fraction is 52% and you are sure that this is the correct ejection fraction, you have to look for causes of this reduced ejection fraction. Maybe the patient is ischemic or otherwise. لكن عشان to diagnose HFpEF اتفقنا ان the patient should have symptoms and signs of heart failure. كونك لقيت ejection fraction which is below normal, you have to look for causes. Most probable underlying coronary artery disease. او اذا كان في left ventricular hypertrophy يبقى it's hypertension. Okay.
Other question?
Yes, it's with regards to the amyloidosis. There is a biomarker, same like in heart failure, by which we can predict the amyloidosis?
قولوا تاني يا دكتور. Yes. An excessive rise. Oh, thank you very much for that question, by the way. لأن أنا فاتني إن أنا أذكر البايوماركرز. An excessive rise of NT-proBNP. So you will see a patient who's short of breath, who seems to have HFpEF, and who has mild to moderate left ventricular hypertrophy, and ejection fraction of like 50, 48. But you might find that NT-proBNP is over 2,000, 3,000. This should always point your attention to infiltrative cardiomyopathies, like Fabry or amyloidosis. By the way, this is the point I wanted to make. في التأمين الصحي إيه مدى استعمال ال NT-BNP وال BNP؟ هل ده موجود؟ التحليل موجود وبيتم استعماله ولا غير موجود؟ حد يعرف؟ هو مش موجود. اوكي. عدم وجود البايو ماركرز is a big problem and we should وهو كمان مشكله ضخمه جدا، بس مشكله بسيط قوي حلها، لان التحاليل سهله خالص واكشلي رخيصه جدا. يعني التامين الصحي لو اشترى الجهاز اللي بيعمل الانتي برو بي ان بي من شكه الصباع زي جهاز السكر اللي في البيت، العيان الواحد هيتكلف اقل من 50 جنيه، اقل من 50 جنيه مصري، والجهاز كله على بعضه ثمنه اقل من 30,000 جنيه، وده الجهاز النمبر 1 في العالم. اوكي؟ فالقصه كلها ان المعامل بتضطر تجيب اجهزه ضخمه جدا عشان تعمل 1000 تحليل في المره الواحده، دي بقى اجهزه بملايين. انما احنا بنتكلم على عياداتنا، عياده الهارت فيلير، جهاز بوينت اوف كير موجود في مصر، مرخصه بيه وزاره الصحه المصريه، معاه شرايط بتطلع بشكل دم في دقيقه واحده 60 ثانيه، الانتي برو بي ان بي اللي بيساعدك في التشخيص تماما. ايه السبب ان الجهاز ده ما يبقاش موجود؟ ما فيش اي سبب. اوكي؟ احنا مش عارفين وما طلبناهوش. التامين الصحي بيقوم بتوفير طافي، بيعمل طافي للعيان صمام ب 25,000 يورو. اوكي؟ فاكيد انه مش سبب ان هو تحليل ب 50 جنيه. ف it is very important ان كل اللي شغالين في فيلد الهارت فيلير وفيلد الكارديولوجي يكونوا بيستعملوا الانتي برو بي ان بي زي ما لازم يكونوا بيستعملوا التروبونين. عدم وجود التحاليل دي اصبح غير مقبول لانه بيحد من قدراتنا، وشكرا جدا على السؤال ده لانه كان فاتني ان انا اذكره.
شكرا.
Thank you very much. سؤالي على النيبيفيلول. كان في سب اناليسيس من السينيورز ترايل على النيبيفيلول في الالديرلي بيشنت، انه above 70 year old patients النيبيفيلول has proved to be benefit outcome regarding mortality regardless of ejection fraction. So do you personally recommend using nebivolol in elderly patients in HFpEF?
Thank you very much. As you well know, nebivolol is one of the vasodilating beta blockers. Both nebivolol and carvedilol are vasodilating beta blockers. However, nebivolol is the most specific beta blocker. It's not a, it works only on the, it doesn't work on beta 1 and beta 2 like, it's the most, بيسموه ايه اللي هو selective. It's the most selective. Sorry, كلمة. So the most selective of all beta blockers is nebivolol, while carvedilol is non-selective. However, carvedilol has huge data also in mortality and heart failure, but nebivolol has the data, as you mentioned, in the seniors trial. And yes, I would use a nebivolol. I would be more inclined to use it because of the data if the patient was elderly. Having said that, if you give it to a patient with cardiac amyloidosis, they're going to feel worse. You'll be surprised. This might be a red flag, by the way, when you give those patients diuretics because they're relying on the filling pressure, or you give them ACE inhibitors or beta blockers, they feel bad. They only feel good with beta blockers if they were very tachycardic or in rapid atrial fibrillation and the beta blocker reduces their heart rate. And you can use them, but with caution.
Also in CHARM trial, IB reserve trial, and BIB heart failure trials, there was no benefit on mortality, but there was benefit in improving NIHA class and in reduced hospitalizations. Do also you recommend using this drug to at least improve NIHA class and reduce hospitalizations in HFpEF patient?
No, because what's happening now is you're right, but you mentioned trials which were good at their time, but we now have trials like the one which was presented today, the Emperor Preserved, which shows reduction of mortality. So we now have treatments. We have two treatments now. One of them is very important, which is sacubitril valsartan, Entresto, which has also been approved by the FDA for HFpEF, especially if the ejection fraction was slightly reduced. So not in the patients with HFpEF with an ejection fraction of 70, but the patients of HFpEF with an ejection fraction of below 50 would benefit from, and that is FDA approved. And that is because when they had another look at the Paragon trial, they found that there were subgroups which really did benefit, which was the group with reduced ejection fraction, still not in the 40, otherwise they would fall in the HFrEF range, but also women. Women were one of the groups which benefited. So now we have proper treatment. There's no point in going back and using treatment which had negative trials. Having said that, suppose your patient, which is not the case in the insurance, انتم محظوظين, suppose the patient is a private patient with no insurance and who cannot afford those treatments, of course we have the older treatments. Yes.
Thank you.
You're welcome.
Question for Professor Mahmoud regarding for Mahmoud.
ايوه انا معاك.
Regarding NT-proBNP in HFpEF, is it the same like HFrEF, or the NT-proBNP is different regarding the value, the screening? What about the biomarkers in HFpEF?
هو ال BNP او NT-proBNP levels in HFpEF are reduced compared to HFrEF. لأن من الوول ستريس في الHFpEF يبقى أقل من الHFrEF، وبالتالي ال BNP values are not so much elevated as we see in HFrEF. كمان there is another problem in most of the HFpEF patients are obese, and we know that the BNP levels in obesity are reduced. فهدول يمكن ال two precautions when asking for BNP in patients with HFpEF. You should consider obesity, which will reduce the levels, and generally the levels are less than those we are used to see in patients with heart failure with reduced ejection fraction.
Great. I have a short question for Professor Hani regarding, do we need to screen every patient going to be subjected to TAVI or surgical aortic valve replacement for amyloidosis?
We might not need to screen them by imaging, but we need to screen them in our minds, okay? So I'll tell you what I do in my own practice. I actually write one line at the bottom saying that I have ruled the possibility of ATTR amyloidosis, which just to show that I have thought about it. Because we know that in some studies, up to 16% of patients going to TAVI had amyloidosis. And you know what? They had worse mortality and they had no improvement in symptoms. So it's disappointing to the patient, and it's also resource consuming to the society, to the country, and to the insurance to give them a treatment which is expensive and risky and does not give them any benefit. While if you treat their amyloidosis, you can then probably perform the TAVI with much improved outcomes. So the short answer to your question, you should screen them clinically. Yes, 100% of the time, all patients, okay? If you screen them clinically and you have red flags, then you can screen by imaging, which is echo, and the technetium scan. Thank you, Professor.
Any question? تفضل.
حضرتك قلت ان المود اوف اكشن ان هو بيعمل جلوكوزوريا وبعدين بيعمل ناتروزوريا يعني دايوريسيس وبياخد معاه بعض المينرالز. طيب لو هو عيان مش دايابيتك يعني الجلوكوز مش عالي، احنا حتى مع استعمال الصوديوم جلوكوز كو ترانسبورتر بعد مده الدايوريسيس بيتوقف على اساس ان مفيش جلوكوز ينزل، وبالتالي الجلوكوز ثريشولد بتاعه بيبقى نورمال، ما بيبقاش فيه جلوكوزوريا في الحته دي. يبقى اعتقد ان في انذر مود اوف اكشن اللي هي بتخش يعني بيبقى ليه كاردياك حاجه مثلا زي كاردياك فيويل او حاجات معينه سعادتك تقول لنا عليها. الجزء الثاني الهيف بيف مينلي في الالدرلي بيشنت. الالدرلي بيشنت احنا بنستعمل الصوديوم جلوكوز كو ترانسبورتر يعني وزاوت كوشن قوي، يعني بنخاف بعد 75. او راي سعادتك ايه يا فندم في الموضوع ده؟
Regarding the mechanism of action, a lot of mechanisms have been suggested, and until now we don't know actually some hidden mechanisms which might explain the benefit regarding metabolic effect in addition to natriuresis, osmotic diuresis, decreased preload, afterload, decreased arterial stiffness, cardiometabolic effect. So many mechanisms have been suggested, but at the end, we have positive trials which demonstrated the benefit. In non-diabetic patients, there was no risk for hypoglycemia. This might indicate that the threshold is different from diabetic and non-diabetic to induce glycosuria. Of course, we know that. So at the end, the drug is safe and no risk for hypoglycemia in non-diabetic. Whatever the mechanisms that have been suggested, sometimes we know a lot about drugs which have mechanisms, but at the end did not prove to improve the outcome. Now we have drug which improve the outcome, mortality, and all endpoints significantly, but the mechanisms are not clear. So this is not, I think from my point of view, not important. Many mechanisms have been described, but at the end, the drug is effective. Okay, so this is the answer.
انا عايز اقول
كنت عايز اقول نقطة تانية إضافة لحضرتك. هو in the diabetic population especially, there is something very interesting إن هو بيرفع الإريثروبويتين وبيقلل الأنيميا significantly, which leads to a very important action of the SGLT2 inhibitors, which is preservation of kidney function. It prevents the patients from going into kidney failure if they haven't crossed the line of the very low EGFR. And this hemopoietic effect is another one which is not fully understood, and we're not even 100% sure if it happens in the non-diabetic population or not. بس أنا مثلا I had concerns, I had several patients admitted with HFpEF and severe hyponatremia. جزء منهم نتيجة diuresis وجزء منهم نتيجة إن أهلهم كانوا بيشربوهم مية كتير، شغل الهبل كده اللي بيتعمل يقول لك شرب الحاج 8 لتر وكلام من ده وهو مش عطشان. And we could use the SGLT2 in those hyponatremic patients with no issues. There was no further deterioration of even though they're supposed to, on the contrary, the patients did well. They improved. And I actually asked specifically, بعت one of the authors of the trials. فالكلام ده أسئلة مهمة جدا، وزي ما بروفيسور مجدي قال, we don't fully understand the mechanism, but there are multiple mechanisms. Thank you.
Thanks for a nice presentation. The last simple question, this hematology test for amyloidosis, is this available or and cheap or not, or is it available on all labs? Because the first time I hear about it.
Thank you very much. Thank you very, very much. When I first started sending the test to labs, I got very confusing results. They did not know what I was talking about. السكرتارية اللي بتستقبل عيانين بتبعت تقول ده ايه كلام من ده. فاتصلت I called the doctors who sent patients for tests for myeloma. And I said, which test do you order for the myeloma? And it's exactly the same test. It's the test of the myeloma. So basically you ask for plasma, immune fixation, protein, electrophoresis. Plasma, immune fixation, it has to be immune fixation. Protein, electrophoresis. And urine, the same test for urine. It's not that important, but it's better. Urine, immune fixation, protein, electrophoresis. And then you ask for plasma free light chains عشان تشوف الألفا كابا واحسن حاجه هي طبعا ان معمل المستشفى اللي احنا شغالين فيه نروح نطلب منه انه يجهز التحاليل دي ونديله بيبرز يقراها عنها عشان يبقى عارف هو ايه، عشان يكتب لنا في التقرير زي ما المعامل بتكتب انه I ruled out AL amyloidosis، لانه ممكن المريض بعد ما احنا يروح لزميل لينا ما عندوش فكره عن القصه فيلخبطه. ف it's quite important انه المعامل تكون عارفه. المعامل المصريه الكبيره التشينز اللي موجوده معظمها بتعمله، بس لازم برضو نوصل جواها عشان العيان ما يروحش يتوه. اتليست اول كام مره نوصل جواها لحد مسؤول ونتفاهم معاه ان احنا عايزين، لان احنا عايزين نوصل لمرحله ان احنا نكتب على التحويل blood and urine test to rule out AL amyloidosis وهو يفهم.
تمام يا فندم.
اوكي، زي ما انا بكتب ليبيد بروفايل مش بقول له دو كوليسترول اتش دي ال دي ال ترايجليسرايدز، بكتب ليبيد بروفايل وهو عارف ده ايه. فانا عايز اكتب له دي عشان نوصل لدي. احنا دلوقتي بنعمل ايجيبشن تاسك فورس على الاميلويدوزس وهنتخاطب مع المعامل وهنوصل ان شاء الله مجرد انه يبقى اسم التحليل وهم يعملوه.
شكرا يا فندم.
Okay, so for the sake of time, I think we have to close this interesting session. Thank you very much, Professor Mahmoud Hassanein, for joining us and for your excellent presentation and the fruitful discussion. Thank you very much. Thank you very much, Professor Hanuragi, for joining us in this interesting session and for your elegant presentation and the excellent discussion. Thank you very much, and we will see you after Salat al-Jumu'ah, inshallah. Shukran. Assalamu alaikum.